Hello, everyone. Welcome to our webinar, International Grand Rounds of Health for the World. It's my absolute pleasure to introduce Dr. Vasileios Lioutas, one of the faculty members in the neurology department of Harvard Medical School. And Dr. Lioutas is specialized in stroke. He is also one of the neurologists in the famous Framingham Study. So please welcome Dr. Lioutas.
Thank you, Mariam. Thank you, everybody. Good afternoon to all of you. Good morning here in the United States. It's 10 a.m. in the morning. Thank you very much for being here. I hope that we won't add to your burden by this presentation. We are going to summarize. Actually, apologize. Let me just put a timer for myself so I don't go over time. We're going to speak about evaluation and management of acute spontaneous intracerebral hemorrhage, which you will allow me to refer to as ICH for the rest of the talk for the sake of brevity. I don't have any disclosures that are relevant to this presentation. So in this talk, we will briefly review the epidemiology and pathophysiology of ICH. And then we will go over the diagnostic workup, medical management, surgical management, and then we will conclude by talking a little bit about severity assessment and prognosis. Before saying anything else, let us define exactly what we're going to be talking about. So, people oftentimes mean different things when they talk about intracerebral hemorrhage. And obviously there are many secondary causes of vascular malformations of various sorts, hemorrhagic transformations of ischemic strokes, venous infarctions often have a hemorrhagic component, and Mneumonia disease, brain tumors, traumas, the list goes on and on. Sorry, I see there's a chat.
No, I just said, please feel free to ask your questions.
Then we have people without any secondary causes. I apologize, guys, someone. Let me just. Apologize for that interruption, guys. So I was saying we have coagulopathy or anticoagulant medications, which is really kind of a no man's land in the sense that it's really difficult to ascertain to what extent the exposure to anticoagulation has contributed to the ICH, but nonetheless, we cannot ignore that. And then, of course, we have the true primary or spontaneous ICH, which is going to be our focus today. And it's primarily hypertensive vasculopathy and cerebral amyloid angiopathy. Let me advance my slide. Here are the two things that we're going to be talking about. So we just spoke about categorization into lobar and deep, and this is basically a topographic distinction. Lobar meaning it's close to the cortex or the juxtacortical areas. And the deep is the one that entails thalamus, basal ganglia, and the brainstem pons. The reason why we have this topographic distinction is that although it's not an absolute distinction, it tends to correspond to different underlying pathophysiology. Lobar ICH being more likely to be related to amyloid angiopathy, while deep ICH is almost exclusively due to hypertensive macroangiopathy. The frequency of ICH worldwide, as you can see, overall, it's about 20 to 25% of all strokes. However, these proportions are very different in various parts of the world. If you hear a talk in a Western or American medical school, we typically say that about 15% of stroke is ICH. Here's what we found in the global burden of disease, about 7-8%. And in Africa, which I'm sure you have a lot to say about, it's as high as 30%. So there's a significant regional variation in how much ICH exists in different places. Interestingly, overall, there is a significant decline in the incidence of ICH, especially when we look at age standardized incidence rate in the last 30-something years. As you can see at the top, this is from the global burden of disease. This is worldwide incidence. On the bottom, there is some data from the Framingham Heart Study running basically in the last 70 years. And you can see that, there was a peak of age-adjusted incidence in the mid to early 90s, and then there's actually a decline in age-adjusted incidence, meaning that we're doing a better job of preventing. That said, because the population is aging, the absolute numbers continue to rise. So the burden of ICH that we have to face continues to increase, although over the course of the time, we're likely to see a decline. The interesting thing on the right-hand side is that there is a significant increase in the older population over time. And the reason for that might be because there's an increased use of anticoagulants, as we will see in just a second. Now, what are the risk factors for ICH? No surprises here. There is a very substantial increase with age. As you can see, there's almost a 10-fold higher rate of ICH in those who are older than 85 compared to those that are younger. Asians have a nearly 2-fold risk compared to other races. Obviously, some genetic predisposition. Blood pressure is the one risk factor that really stands out. No surprise here. What you can see here, this is again data from the Framingham study, where we have the opportunity to distinguish between deep and lobar ICH. And you can see that the interesting thing is, unsurprisingly, hypertension predisposes you to deep ICH, but it also contributes to lobar ICH as well. So it's not just the amyloid angiopathy. And then the other thing that really stands out is obviously the ApoE4 allele, especially the homozygosity. As you can see, you have homozygous E4 variant, your risk of having a lobar ICH goes up by 5 to 6 times. And this is what happens worldwide. And you can see, and I'm sure you have a lot to say about that as well, that hypertension really is the one risk factor that increases your risk of ICH. And this is more profound outside of Western societies. And then again, no surprise, anything that's good for your vascular health is also good for preventing ICH. So healthy diet, as you can see, reduces the risk of ICH, physical activity as well. And on the contrary, alcohol intake increases your risk by almost 2-fold to have ICH. A few words about anticoagulation, because this is increasingly used. The first and most widespread anticoagulant is obviously warfarin, and this is a meta-analysis of randomized trials, and you can see that it definitely predisposes people to ICH, and compared to aspirin, you can see there's a 2-fold higher risk of intracerebral hemorrhage with warfarin, so well established. Thankfully, with the advent of secondary prevention, we now have a DOACs, the Bigatron, Rivaroxaban, Edoxaban, Apixaban, and the likes. And to not belabor the point too much, but in pooled analysis of all randomized trials, we've seen a significantly lower risk of intracerebral hemorrhage compared to warfarin. So much safer options compared to warfarin, and much lower risk of intracerebral hemorrhage. As we alluded to before, there is an overall increased tendency of using anticoagulants in the population, especially older people. Here's just the manifestation of that. As you can see, in the 4 years between 2005 2008, there's a significant increase. We saw the same thing in the Framingham study. Again, this is a population-based study in the United States. It has the benefit of very, very thorough surveillance of a population over 70 years. And we can see that the usage of anticoagulants has really increased almost quadrupled between the 1980s, 1990s, and 2000s. And that probably is what accounts for this increased risk of hemorrhage in the older parts of the population. Now, how does it happen? Moving on to the pathophysiology, okay? In contrary to ischemic stroke, where we have a good conceptual model, we know there's a clot that goes and gets stuck in the blood vessel, and then we have ischemia and all the cascade of events. With ICH, we have never actually witnessed the onset of it, but the conceptual model is that there's obviously some rupture of a fragile vessel, and the reason being either long-standing structural changes from exposure to hypertension, or amyloid angiopathy making the blood vessel wall more friable. And if you put this tissue under the microscope, for hypertensive microangiopathy, you will see a lot of microhemorrhages and microinfarcts in the surrounding tissue, as you can see here, just betraying the long-term effect of uncontrolled hypertension. And this is how it looks like. On the contrary, amyloid angiopathy tends to affect the superficial penetrating vessels. And if you do a Congo stain, you will see amyloid deposition in the vessel wall. The vessels become friable, they rupture, and then the blood spills into the parenchyma. And what happens is that the initial insult is basically pure mechanics. So you have extravasation of blood into the brain tissue. There's a hematoma that forms, and the hematoma disrupts the structure of the brain tissue, pushes, and just causes destruction by blunt mechanical force. And that sometimes leads into expansion of the hematoma, and of course there's disruption of neurons and glial cells. The expansion of the hematoma is a very important and interesting part of the ICH pathophysiology, as you will see a significant therapeutic target as well. Again, we're not entirely sure how it happens and why it happens in some people and doesn't happen in other people. There's two postulated mechanisms. One is that really you think of a ruptured vessel as a hose with a hole that continues to leak, and you need to patch it up. The other, which is also very interesting, is that there is an avalanche effect, meaning that you have the initial small hematoma, and then the way that this stretches the tissue around it, it ruptures small vessels on the rim of the hematoma, which in turn they bleed more and the hematoma expands. So it's like a self-perpetuating cycle, which obviously at some point it finishes, and it's because there's too much mechanical pressure. Now, the hematoma expansion, as I said, is very important, and it's very time sensitive. So it happens really quickly, and mostly the first 3 to 6 hours, and up to 70% within the first 24 hours. So it's not something that occurs over time. It's an acute phenomenon for the most part. The question is, what is a clinically meaningful hematoma expansion? Because, if you really do serial CAT scans, you will see some expansion in almost every hemorrhage, There are various definitions in literature. Some people go by relative increase, so 33%, so 1/3 increase in the volume. And some people go by absolute increase, and the cutoffs that are being used are 6 ml or 12.5 ml. And as you can see, the mortality increases significantly as the hematoma volume increases as well. And correspondingly, the chance of a good outcome goes down. And here you can just see, the magnitude of the effect. For every ml increase, we have a corresponding significant decrease in favorable outcome or increase in mortality. Now, what happens if the patient is also exposed to anticoagulation? We spoke about that in the beginning a little bit. It seems, and this is a topic that merits its own, separate discussion, but for the sake of brevity here, we'll say that it seems that patients who have blood thinner exposure and the INR is elevated, they tend to have a higher volume if you keep everything else stable. So, same age, same blood pressure, same everything, you end up with a significantly higher hematoma volume, which kind of makes sense if you think that, it increases your likelihood of continuing to bleed, and, the hemostatic mechanism of your own body are impaired. And here you can see that this translates into worse outcomes in those who are exposed to anticoagulants, especially warfarin. On the left-hand side, you can see that consistently patients with ICH who are exposed to warfarin have a significantly higher mortality. There are the blue column here. You can see, it's about absolute difference of, anywhere from 12 to 15%. And then here you can see how exposure to warfarin independently increases risk of poor outcome. To not belabor the point here, 3 times or 2.5 to 3-fold higher risk of bleeding. Now, in addition to what we just described, the primary injury, which is mostly kind of a mechanical disruption phenomenon, there is also secondary brain damage, which is probably just as important. And it's what really differentiates ICH from ischemic stroke. It's a more kind of slowly evolving process. And there's a lot of, as you can see, inflammatory reaction. There is specifically iron toxicity. So as the hemoglobin is slowly degraded, it releases free radicals and other toxic products that really exacerbate the primary insult to the brain. And of course, this is problematic, but also presents very attractive therapeutic targets as well. So what can we do about therapeutics? We can move into 3 main different directions. One is obviously limiting the hematoma expansion, as we just discussed. The second is to really directly go and, take out the hematoma. Basically, we're talking about surgical techniques. And of course, the third is targeting the secondary effects of ICH. And there's many, postulated and proposed research pathways. We will speak mostly about those that are have been tried in clinical trials and are relevant to our clinical practice. So the first thing is before we say anything else, is talk about the workup. Okay. So the evaluation always starts with imaging, and the first imaging study, and really for the most part, the only study that you need is a non-contrast head CT. It tells you a lot of things. Tells you about the hematoma location, which, as we've said, is associated with location and, of course, risk and prognosis. It can also tell us about hematoma size and whether it's intraventricular expansion. Something that is very important and helps to be familiar with is this widespread method of computing the hematoma volume, because it helps where you stand with regards to prognosis, is the Abc2 method. You basically visually inspect the hematoma, the CAT scan, and you choose the slide where you think that the hematoma is biggest, and then you kind of draw the largest diameter. That's your A. Here's A. And then staying on the same slide, then you choose the greatest diameter that's perpendicular to A. That's your B. The C is where people get a little confused, and it's your vertical diameter, your Z-axis, if you will. For that one, you have to scroll up and down and measure or count on how many slices you actually have your hemorrhage, and then multiply that by the slice thickness. Typically, slice thickness is 0.5 centimeters, 5 millimeters. And then you multiply all of these things and divide by 2, and that gives you your hemorrhage volume. Of course, it's an approximation, and it assumes your bleed is ellipsoid in shape, but it's widely used both in clinical practice and research, and it's fast and quite easily done. Additional workup, MRI can help. There is unexpected diagnosis in about 33% of cases, if you believe the literature. I would say that our experience is that this is probably an overestimation. We don't see very many secondary causes, actually. I would say in our center, which we've been looking at our data recently with one of our trainees, we discover a secondary cause in about 4 to 5%. So it's not necessarily something that everybody should have, but select cases. Suspicion for a secondary cause, meaning that there's some underlying lesion that we discussed in the beginning. Patients who had a long-standing history or preceding headache, neurological, or other symptoms. If the shape of the ICH is very atypical, meaning, multi-finger, very extensive, as I said, multifocal ICH, and then if there's a lot of edema that's out of proportion to the size, meaning that there must have been some underlying lesion there. And then, of course, we have MRI markers that help provide hints for the etiology, and very specifically for amyloid angiopathy. And I'm sure you've heard about the microbleeds here in the blood-sensitive sequences of MRI. If you see a patient who has strictly lobar microbleeds, meaning those close to the cortex, that really increases your suspicion that the patient has underlying amyloid angiopathy. A more recently described marker is superficial Synderosis, and basically that's just blood products in the cell side. It's thought to be because, as we saw in the beginning, amyloid angiopathy tends to affect the penetrating vessels. Superficial penetrating vessels may cause recurrent microhemorrhages that are not clinically significant, but manifest in brain MRI. They're both markers for increased future risk of ICH. I think I have made a good case right now that ICH is really an emergency and should be treated with the same sense of urgency as ischemic stroke, because its expansion is very time sensitive, and you have a narrow time window where you can actually limit the extent of the damage. So besides imaging, obviously, important to obtain coagulation tests, especially those who are exposed to vitamin K antagonists. It is important, to the extent it's possible, that the patient is admitted to either a stroke unit or neuro ICU if available, and frequent neurologic assessments, especially early on. Pretty similar to what we do in patients who receive IV TPA for ischemic stroke. Remember that hematoma expansion occurs early. Definitely repeat a head CT in the first 24 hours to ensure that the hematoma is stable, not expanding. Those who have bleeds in the posterior fossa are their own separate category. As you well know, the risk of edema, hydrocephalus, herniation is very high, and neurosurgery should be standby for possible craniotomy evacuation. The main problem that one may encounter, and the main clinical signs we have to observe, are signs of intracranial pressure increase. Patient may develop a hydrocephalus because there's mass effect. So the first thing one would see is probably increased somnolence. The patient becomes a little obtunded. It may not happen very obviously, very abruptly. The patient may be slowly drifting, and that is why it's important to have frequent assessments, as I said. So they become difficult to arouse, vomiting, and of course, changes in pupillary reaction, lose a pupil, immediate head CT, and then, if there is something to be intervened upon, you intervene upon. So how do we what can we do besides monitoring the patients and doing scans? So the first thing we will talk about is blood pressure lowering. And this is probably the most widely discussed issue or topic in ICH management. There are two big trials we will just go over very briefly. They're very frequently cited in literature. So there's the Interactive trial, which is a very large phase 3 trial, whereby the patients were assigned to either achieve intensive blood pressure reduction within 1 hour from presentation to the hospital, or just go by the guidelines, which was just to reduce the blood pressure to less than 180 millimeters of mercury. Basically, to not belabor the point too much, the trial did not show a significant difference in the primary efficacy endpoint, and no difference in hematoma expansion and volume. There was a possible trend towards a slightly better modified ranking scale at 90 days, but not a very impressive effect. This was followed by another study, also randomized phase 3 trial called Attack2. As you can see, 1,000 patients. The protocols for these these studies were slightly different in the sense that for Attack2, everybody received intravenous nicardipine and had a more intensive blood pressure lowering, and the randomization was also very early, within 3 hours from symptom onset. They had to stop the study prematurely for futility, and as you can see, there was no significant difference at all in the 90-day efficacy outcome. And in addition, they saw a high rate of renal complications, kidney failure, in those who received the intensive treatment, perhaps because of the very aggressive lowering of the blood pressure. So that has left us with a bit of a question mark as to what should be done. Then they did a pooled analysis of the two trials, and what they seem to find is that the one thing that seems to make a difference is the magnitude of decrease. So not everyone benefits the same way from lowering the blood pressure, and those who are in the two extremes, so very minor or very significant decreases of blood pressure, tend to not do so well. Those who are somewhere in the middle seem to probably benefit, as you can see here primarily. So functional recovery, you can see that those who are somewhere in between, in the 20 to 60 millimeters of mercury, magnitude of blood pressure decline, they did well. If you overdo it, if you decrease the blood pressure by a lot, more than 60, or too little, patients don't do so well, and you can actually make an argument they're harmed if you are very aggressive. Practically, these are usually patients who probably have long-standing hypertension, and they have been living in high blood pressures of 180, 200 for many years. They present to us, and we very aggressively lower the blood pressure to like 120, and that's bound to cause some complications. So the guidelines are correspondingly non-committal in this particular issue. The European guidelines were recently published specifically for this issue, and basically, as you can see, if you take all clinical trials have been done in the matter and look at long-term outcome, there seems to be no significant difference when you intensively lower the blood pressure. When you stratify by timing, there seems to be maybe a trend towards benefit when you lower the blood pressure a little earlier in the course, but overall things remain quite murky. And the recommendation is that basically we are not sure whether there is a significant benefit and whether the risk outweighs the benefit or not. In patients who present hyperacutely, though, it is reasonable to lower the blood pressure to below 140 milligrams to reduce the hematoma expansion. The American ICH guideline is actually under review and preparation, so we will see exactly how it's phrased. but definitely not a one-size-fits-all strategy. So practically, what do we do, you may ask me? So the first thing is obviously go monitor the blood pressure closely. Instead of giving a one-size-fits-all, it seems like bringing the blood pressure to 140 millimeters of mercury seems to be safe for most patients. It's important to try to avoid wide fluctuations and significant magnitude drops. It is always preferable, if possible, to use short-acting intravenous agents who have a predictable response, and specifically nicardipine or labetalol. I know that in many parts of the world, these two are not available, and inevitably people use hydralazine, which is effective, but also very unpredictable. That's probably the third line option that we have. Using those easily titratable agents helps a lot to avoid those wild fluctuations that seem to harm the patient so much. Moving on from blood pressure into hemostasis. So rapid correction of coagulopathy, as we discussed before, we saw that high INR exposure to warfarin is associated with poor outcome. So it makes good sense that we would aggressively try to correct the coagulopathy and speed up the patching of the leaking blood vessel and reduce the hematoma expansion. So there are several trials. I won't bother you with all of them. So this is one trial where they didn't limit the trial to patients exposed to warfarin. They just took everybody with the assumption that everyone has some leakage in the acute phase. And they gave the patients either placebo or activated factor 7. And although they saw a significant reduction in ICH growth in those who received the high dose of factor 7, this did not translate into functional benefit or survival. So this is not something that's being done on everyday practice. Subsequently, people decided to use an imaging marker of continuous blood extravasation to enroll patients that are probably likely to still be extravasating blood, and they use something called the spot sign. The spot sign is when you do a CT angiogram and you see a very bright sign inside of the hematoma. It's supposed to signify an underlying blood vessel that's continuing to leak. And the idea was that these are the patients who are more likely to benefit from giving a hemostatic agent. Unfortunately, this didn't work out in the randomized trial, although they chose the patients that were supposed to be high risk. And they found no difference in hematoma expansion or functional outcome. There was a similar trial using tranexamic acid, and similarly, the results were negative. So I won't present you that trial study in the interest of time. I will say that there is an ongoing trial called FASTEST, and the idea is that perhaps if we intervene really very, very early, as in less than 2 hours from symptom onset, maybe we'll have some benefit. We shall see how this works. The problem obviously is that this will be applicable to only a very small proportion of ICH, because who presents within 2 hours from symptom onset to be given this kind of management. Now, anticoagulation reversal. We don't have any randomized data. We have observational data, and this is the basis for what we do in clinical practice. The biggest study that we often cite to guide our decision-making here is this observational study from Germany. Basically, what they saw was that achieving a lower INR resulted in significantly lower chance of hematoma enlargement, and that this was time sensitive. So you had to achieve it, and you had to do it fast, because if you go beyond 4 to 5 hours, your reversal doesn't really work. The The magic number for INR was 1.3, and that is our current target. So whenever someone presents with exposure to warfarin, we target INR of 1.4 or less. Okay, here you can actually see how the time-sensitive component works. So if you do it fast, it works better. Now, what do you do, and what can you use to reverse the INR? So there are different options out there. Obviously, we have fresh frozen plasma. You can see here. That's probably the most widely available. It contains several coagulation factors. Its effect is not very, very fast. It takes a few hours. And in addition to that, it takes some processing time. It has to be thawed before given to the patient. So it's not immediately available. And in addition to that, we have to give high volumes, which is about 2 liters, which is not something very good for patients who may go into pulmonary edema and of course may have other allergic transfusion reactions. The second thing, which seems to be by far the best, is prothrombic complex concentrate, PCC. Contains 3 or 4 factors, as you can see. We definitely prefer the 4-factor PCC. It works much faster than frozen plasma, and it doesn't require any significant processing time. On the opposite side, it's quite pricey and not available throughout the world. The other benefit it has, the concentration of coagulation factors is very high. So we only need very small volumes, about 20 to 40 ml. And then, of course, we have the activated factor 7, which we discussed. It's not used currently in clinical practice. So definitely we prefer the prothrombic complex concentrate if available, if not fresh frozen plasma. And here, just basically showing how much better is the 4-factor PCC compared to fresh frozen plasma. You can see that it achieves the reversal much faster compared to plasma, and it does not lead to any significant risk in thromboembolic complications. This is one trial that was specifically targeted to ICH, randomized trial, as you can see, plasma versus complex concentrate. The primary outcome was to see how quickly we can achieve INR reversal. And you can see that prothrombic complex concentrate is vastly better than fresh frozen plasma. This trial wasn't powered to detect differences in functional outcomes, so we didn't see anything. However, although not powered for that, they did see a significant improvement in imaging markers. So hematoma expansion was much lower in those who received fresh frozen plasma. Sorry, I apologize, complex concentrate. So for that reason, we just really very much prefer to use prothrombic complex concentrate if available. Now, what happens with the new anticoagulants? Those reversal agents we just spoke about, they don't really work very well for those new anticoagulants. We'll speak briefly about dabigatran or Pradaxa. As you know, it's a thrombin inhibitor. And one of the main concerns early on was that, okay, it works well for preventing ischemic strokes in atrial fibrillation, but what happens if the patient bleeds? There's nothing we can do. Well, thankfully now we have something that we can do, and there is an antidote. It's called idarucizumab. It's a monoclonal antibody, and it removes dabigatran from the blood circulation. And it's approved for management of hemorrhage that has occurred in the context of dabigatran. Although the trial that was done was not really a randomized control trial, we can see that the patients who received dabigatran in this observational study did a lot better than those who had dabigatran in the clinical trial, where the idarucizumab was not available. The drawback, of course, is availability and price, as with everything else. The factor Xa inhibitors, we have the edoxaban, apixaban, and rivaroxaban. And for those, we have something called andexanet, which is basically a decoy protein that binds to the factor Xa inhibitor and deactivates it. Without belaboring the results of the trial very much, there was a significant reduction in circulating factor Xa inhibitors and thrombin time in the patients who received this antidote. The clinical outcomes were good, although again, the trial was not really randomized. It was an observational cohort for the most part. In any case, it is also approved for reversal of factor Xa inhibitor. I will say that it's extremely costly. Even here in the United States, we have limited supply and we have to implement very specific criteria on whom to use it. So it exists, but not readily available. Moving on to antiplatelet associated or patients who have been given antiplatelets. Is there any value in using platelet transfusions? And the answer is basically no, supported by this multi-center phase 3 trial, which was done mostly in Europe. And to cut it short, the patients who received transfusion, they actually did worse than those who received standard care. So definitely not something that is recommended to be done. Do not give platelet transfusion to the patients who have been given antiplatelets. Patients who have thrombocytopenia are a slightly different story. And we usually prefer to have a platelet count of about 100,000 or above, if possible, or at least 50,000. Mind you, this is not coming from any specific empirical data. It's just common sense. We prefer to keep the platelets above a certain threshold. Okay, so this trial doesn't apply to patients with thrombocytopenia. It's just your average patient with ICH who's been taking aspirin or Plavix or something like that, and they come to the hospital. You should not be giving them transfusion of platelets. So to summarize, no hemostatic agent has been shown to improve outcome in the general population. Again, not those who are exposed to anticoagulation. Platelet transfusion is not a thing to do. It's important to check coagulation tests on all ICH patients. If a vitamin K antagonist like warfarin has been given, we hold it. We give the patient vitamin K, and then we reverse the INR very rapidly and preferably in the first 5 hours. As we discussed extensively, if possible, we prefer prothrombic complex concentrate over frozen plasma, and the INR aim is less than 1.4. Okay, because some patients have a rebound after the first 24 hours, it's important to monitor for the next 2 or 3 days to make sure the INR remains where we want it to be. For dabigatran, idarucizumab recommended if available. For factor Xa inhibitors and dexanet. If you don't have any of that, of course, use what you have, plasma or PCC. And now moving on to surgical management and hematoma reduction. Okay. And we're going to talk both about open craniotomy and evacuation and also minimally invasive techniques. One would argue that operating and removing the clot would be the no-brainer, the easier thing to do, the more straightforward thing to do. You know, you remove the clot, everything, you know, goes well. You don't expose the patient to all this secondary injury we spoke about. Others, it didn't work like that. It's worth mentioning the 2 main trials that have led to our current practice. There was the STITCH trial, which was completed in 2005 and randomized patients, 1,000 patients to either receive craniotomy or just medical management. And surprisingly, there was no significant difference in functional outcomes, with the possible exception of those who had very superficial bleeds, meaning less than 1 centimeter from the surface of the brain. The idea was that perhaps there is a benefit But if you mess up with the brain too much in your effort to remove the clot, you cause more damage that really kind of negates the effect of removing the blood clot. And therefore, there was a follow-up study that focused on the patients who had cortical bleeds, hoping that we'll see a benefit in this group of patients. And unfortunately, this didn't work out well either. So although we had high hopes, we did not see a benefit with evacuation of the hematoma. So it is done on specific, select cases sometimes, but by no means it's standard of care to evacuate the hematoma in all ICH patients. Naturally, the follow-up idea was to use minimally invasive techniques, hoping that we don't cause any tissue damage. And basically what they do, they insert a microcatheter using CAT scan guidance. And surprisingly, we give TPA. The idea is that, there's a formed clot, and by using TPA, you dissolve the clot and then you suction it out. Of course, you have to first establish stability, which means that you cannot really intervene very quickly. But the way it works is that after they establish stability, they give 9 doses of IV TPA or, remove 15 ml. And what seemed to be happening is that there was some trend towards better outcome, but there were infections and other disadvantages, and the overall outcome was not positive. So again, not a standard of care. However, there is a lot of interest in this particular approach with improved devices and better protocols. So there are several ongoing studies, and we may see some changes in practice in the near future based on minimally invasive surgical techniques. So to summarize surgical approach, craniotomy evacuation, not performed routinely in supratentorial bleeds, okay? On a case-by-case basis, could be offered, especially in those with very superficial ICH with good prognosis, or life-saving in those who are herniating. I should emphasize that this is all referent to supratentorial bleeds. The posterior fossa hemorrhages are an exception. Craniotomy evacuation are life-saving and offered to all patients who show signs of herniation or increased pressure. Minimally invasive clot, lysis and aspiration are very promising, not proven yet, and we're hoping to have news from that field soon. Now, intraventricular extension. Having blood in the ventricles is a poor prognostic factor. It just makes everything worse. And naturally, there has been interest in treating those patients. Again, there's a trial whereby they inserted a catheter into the brain, a ventricular drain, and again, gave TPA and suction. It was a fairly big trial, very similar protocol with what I just described, minimally invasive trials. And although we did see some trend towards better outcome, the study did not reach its efficacy endpoint. So again, it's not a standard of care. There is some ongoing interest in repeating the trial with improved protocol. The idea that if you put actually 2 drains and you remove a lot of blood, patients will do better. I will say that although it's not the standard of care, it's something that we do on a case-by-case basis. If there's a lot of blood in the ventricles and the patient shows signs of hydrocephalus and increased ICP, we use this technique. We insert, the neurosurgeons insert a ventricular drain, and we instill TPA, and then the drain suctions the last blood, and sometimes the patients do better. I'm going to go back. I should say that in addition to what we discussed already, there are some common sense, stroke interventions and that need to be followed in all patients. Dysphagia screening is very important, just like ischemic stroke. All patients before fitting should be screened. Infections and hyperthermia really worsen outcome and should be treated pretty aggressively. Prophylactic anti-epileptic drug is not recommended. It's often done because there's this idea that having blood irritates the brain, which is partially true, but any study that was done using prophylactic anti-epileptics did not show a benefit and actually showed the trend towards worsening. So we only use it if the patient has seizures. The thromboprophylaxis, so subcutaneous heparin to prevent deep vein thrombosis. Actually, once you establish that the bleed is stable in the first 24, 48, 72 hours, you can resume safely thermoprophylaxis. In the interim, obviously, we use compression devices. Subcutaneous heparin, low molecular weight heparin, whatever one uses. And then, of course, physical occupational therapy assessment is very important, just with ischemic stroke. Now, the prognosis. So I would say that overall, there is a little bit of pessimism and nihilism related to ICH. It's thought of as a very poor outcome stroke. And to some extent, that is true. But it seems more and more that this is in part because of the way we approach it as clinicians. You may or may not know about the ICH score, something we use very frequently to communicate the severity of the bleed. And it's a score that entails several different factors. As you can see, the clinical severity using Glasgow Coma scale, hematoma volume, dichotomized as 30 ml less or more, and then presence of IVH and the infranatorial origin and age, with the cutoff being 80 years. So the maximum score is 6 and the minimum is 0, of course. And as you can see, higher score increases your mortality significantly, or is associated with increased mortality. Now, the problem is that this was never meant to be a prognosticating tool. It was meant to be a communication tool between physicians to something like the stroke scale, to just communicate the severity. Unfortunately, it has been used extensively to prognosticate. And in that way, it changes people's approach, physicians' approach to the patients. And this leads to worse outcomes because if you don't treat someone aggressively, they're more likely to actually die. So self-fulfilling prophecies are very frequent in ICH. So we advise significant caution. Firstly, because there is a very significant variability between physicians in mortality estimations. And you can see here on the left-hand side, just 4 characteristic examples. And the estimated mortality by different physicians were all over the place for the same patients. On the right-hand side, you can see what happens if you disregard the ICH score and just give the patients a full chance. They actually do a lot better than predicted by the ICH score. So do not use it for prognostication. Use it to estimate severity, but still offer the patients a full chance. The same thing here. Basically, you can see that assuming a less aggressive stance, it really worsens the patient outcomes. And you can see that withdrawal of medical support and do not resuscitate orders, just reflecting a less aggressive stance by the physicians just worsens predictions. So the recommendation is that aggressive full care early after ICH is recommended, at least until the second full day of hospitalization. So do not fall into the trap of early withdrawal just because the patient doesn't look very good or the bleed looks impressive with the CAT scan. Sometimes these patients do quite well. And a few words about the outcome. So we're primed to look at outcomes at 90-day windows. This is where clinical trials have done in the past, mostly based on ischemic stroke. However, as we've seen, ICH has a very different pathophysiologic mechanism, and the trajectory of recovery is probably very different. Therefore, 3 months is not enough for ICH. This patient needs to be given a longer time to recover. And I will just show you, highlight this by using a recent clinical trial that was a placebo-controlled trial using deferoxamine. We won't speak about the trial itself. I'll just show you what happens to the placebo group. So just your ordinary ICH patient who is given a full chance. So this is the placebo group at day 90 and day 180. And you can see how the modified Rankin score has shifted towards the more favorable by doing nothing, no intervention, just regular care between these two dates. So ICH patients continue to improve beyond 90 days. So the message is, do not be pessimistic about it. Yes, it has high mortality. It's a bad kind of stroke to have, but the patients can do surprisingly well if supported through the acute phase with all the things we mentioned. I would like to thank you for your attention. I'm 53 minutes and 15 seconds, so not terribly over time, and I'm happy to take questions. I can see 3 in the Q&A already by Dr. Bob. So the first question is, which medication do we use in US hospitals to lower high blood pressure? So definitely our preferred agent is nicardipine, which is an intravenous calcium channel blocker. It is very easy to titrate over short periods of time, and you can achieve a very kind of smooth control of blood pressure, rapid and smooth. So that's ideal. Acknowledge that this is not always available, even within US hospitals. So the second agent that we use is intravenous labetalol, which is almost just as good as nicardipine, but of course, because of the beta blockade, sometimes it causes bradycardia. So a little less preferred in general. And then if nothing else exists, then we use hydralazine, which is of course much less predictable, unfortunately, with wider fluctuations. It's not ideal, but it's better than nothing. And lastly, of course, you have Nitropreside. We tend to, so Nitropreside is not so preferred in the context of ICH for one reason. It causes vasodilation, as you know, and we're worrying that it could worsen the expansion of the hematoma and the increase of ICP, intracranial pressure in the acute phase. So we tend to avoid it. But if the patient's in hypertensive crisis and you have nothing else to do, you got to use it. All right. I hope that answers the question. So Dr. Bai is asking what the protocol. What medication? So as you may have realized, there are no specific medications for ICH, save for blood pressure control. We do supportive care, frequent monitoring, interventions if needed. So if the patient has significant expansion and they need to have a drain placed, we do that. We really try to help them get through the acute phase, honestly, guys, and hope that then they will recover after that. We focus a lot on early initiation of, DVT prophylaxis. So we're not aggressive, but you don't have to be very, very conservative in that front. So if the patient has a stable bleed, you resume DVT prophylaxis. You're pretty aggressive with all the supportive stroke care. So preventing aspiration pneumonia, so dysphagia screening, physical occupational therapy, Also, what I mentioned in the very end, fight this instinct to fall into the trap of pessimism. Yes, these patients may not look so good in the acute phase. You support them. They oftentimes do much better than expected or hoped for. We don't have any other medications. There have been many efforts, things like deferoxamine to fight the iron toxicity we spoke about. That didn't work out. Tranexamic acid to limit the expansion didn't work out. The factor 7, as I said, hasn't worked out. We don't do it on everybody. Patients who have been exposed to warfarin, we, as I said, we very aggressively lower the INR. We give prothrombic composite concentrate or fresh frozen plasma, whatever is available. And then it's general supportive stroke care. The main intervention is really the stroke unit. Now, what would you do if a neurosurgeon TPA was not available? I'm going to assume, so this is referring to intraventricular hemorrhage, I suppose. In that case, you're very limited. You can try to use, mannitol. You can try to use hypertonic saline to, reduce the edema and the blood pressure. But, these are temporizing measures and they don't always work very well. You need a neurosurgeon if the patient is developing increased ICP. Hyperventilation also works, but for a very narrow window of time, just reduces your ICP temporarily, but you cannot do it forever, obviously. So you really need a neurosurgeon around sometimes to manage patients with ICH. There's no way out of this. Any other questions?
Thank you so much, Dr. Lioutas. Is there any other question? So, Dr. Lioutas, I remember you said that you have
someone has a question. It's not like Mariam.
Yes, from Cameroon. Hello again. We are still awake.
Congratulations.
I'm just just joking. It was so interesting, and I was looking around the room for you, and nobody was asleep. It was so captivating and simplified explanations, and we learned a lot. So thank you very much. So we do have a few questions in the group.
Super.
Yeah.
Okay, thank you very much for the lecture. I wanted to ask, in our setting, we have just IV labetalol for lowering blood pressure. I just wanted to know, in terms of IV infusion and regular start doses, like which one is superior and better in controlling the BP, the blood pressure?
So that's an excellent question. So I can tell you that, especially in the very acute phase, we always prefer the intravenous infusion as a drip, just because it has a more predictable effect and easy to titrate. Obviously, if there is nursing shortage and it's difficult to, from a staffing standpoint to do it, frequent injections is the way to go. Having labetalol is a very good intervention. We use it very frequently here also. So it's a good medication. Just the infusion seems to have a smoother calibration and titration, so you avoid those excesses. And as you remember, see the big magnitude of blood pressure reduction seems to not be a good thing. So you avoid those by using intravenous infusion. That said, once you're past the first 24, 48 hours, obviously you can start introducing oral medications, titrating them up, in the effort to reduce the intravenous ones. I should have said this. I don't know if you have it available, but we really like to use Captopril because it's a short-acting ACE inhibitor that's easy to titrate. You use it 3 times a day. And then once we reach our target dose, we convert to lisinopril. But you can use anything else really, hydrochlorothiazide, another ACE inhibitor, or whatever else is available. Things like amlodipine, calcium channel blockers, tend to have a slower onset of action. So we don't typically go to them in the early days. We may use them later on if we're not achieving our target while the patient is still in the hospital. But we definitely prefer shorter acting agents that can be titrated easily.
Yes, so thank you very much. So at the beginning, you were already asking about the experience we have here in Cameroon.
Yes.
So a brief talk about that. So we do see a lot of patients with intracerebral hemorrhage around here. And as you already mentioned, there is a clear aura of pessimism whenever we have these cases, because more often than not, the prognosis isn't quite good and the outcomes are not really good, unfortunately. So we have a lot of limitations in our ability to manage these patients. I was glad to read that surgical intervention did not really prove to be quite useful because we don't offer that in our facility. So our patients are not missing much.
No, we rarely do that. To be honest, with the exception of posterior fossa hemorrhages, we do maybe 2 surgeries a year. And I'm talking about at least 200 cases we see every year in the hospital. So it's not very frequently done at all.
Okay, so other limitations include availability, like for example, for the vitamin K antagonist related bleeding, we can't provide the PCC, we can't provide FFP, unfortunately. If the patient was on rivaroxaban, which we actually offer at our facility, we don't have andexanet alpha, unfortunately. So we focus for the vitamin K antagonist, we focus on giving vitamin K and doing our supportive care.
Yeah. So I will say, Dr. Chinta, I will say something, which I didn't have time to go into too much detail. So you may not be missing out on a whole lot. So the study I showed you from Germany, that is the basis for almost everything that we do. As you noticed, it's observational, and it's also basically looking at hematoma expansion. It wasn't focused on functional outcome. And there's a lot of skepticism actually as to whether correcting the INR has a clinical impact or not. So it's a controversial thing, actually. We do it because it seems to limit the hematoma expansion because we don't have much else to do, but it's not necessarily something that works all the time. So that's some of the limitations with ICH, unfortunately. The same goes with andexanet. I can tell you that our supply is limited. It's very pricey. Hold your breath, but it costs about $50,000 here in the United States for a full dose of andexanet. And for that reason, we have very strict criteria, and we don't use it very frequently either.
Okay, thank you. Well, the other limitation is financial, but you could have guessed that. And we can't get a CT scan within 24 hours as you recommended to assess for stability of the hematoma. So usually we do that clinically, but I'm guessing this is also going to limit our ability to appropriately take care of these patients. What's your comment on that, assessing it clinically?
So first of all, as you said, you go with what you have, and there's no way around this. And you guys might be a little better clinicians than we are, just because you use your clinical judgment more than we do. We rely a lot more on imaging. So this can cut both ways. So we do it because, firstly, because we can, and because it seems to help a little bit. Does it always make a difference? I don't know that that's the case. And oftentimes, the imaging that we do is maybe in reaction to clinical change. So, what drives what remains somewhat controversial. The one area where it really helps us, I would say, is, giving us a sense of security or safety that the hematoma is not expanding and we can start the thromboprophylaxis. Otherwise, I think it's reasonable to, use your resources, wisely, and, use your clinical acumen, and go from there,
So thank you. I'm going to conclude with this. So I noticed you didn't really mention about strategies to reduce perihematomal edema or inflammation. So what's your comments about that? A lot of things have been attempted. Which one do you recommend or not recommend, and for what reasons?
So thank you for asking this question. We could talk very, very much at length about this. The reality is nothing has been proven to work specific for perhematoma edema. We sometimes will use mannitol or 3% to reduce the mass effect of the bleed. The perihematoma edema itself has been a target of various interventions, from deferoxamine to minocycline to other, experimental interventions. There are some challenges, firstly, on how you define it, how you measure it. Without going into much technical detail, there's, absolute measures, relative measures. At which time point do you measure it, and at which time point does it become consequential? So there's a lot of uncertainty around this particular aspect of ICH, and it's a very attractive target, but at this point, it's primarily, or I would say exclusively, in the clinical research domain, and not so much in clinical practice.
Great. That's all we had here. So thank you very much. I personally can't wait to go to the Health for the World site and go through this again. So thanks a lot.
Can I ask you a question, if you don't mind me?
Yes, please.
Epidemiology. So I wanted to ask you, firstly, what proportion of your strokes are hemorrhagic? And secondly, if you have a sense of those hemorrhagic strokes, what proportion is lower and what proportion is deep?
It is, unfortunately, we don't have clear data. There is an ongoing stroke database that involves our facility. So maybe in a few months or even a year, we may have more precise data for you. But what I can tell so far is that we clearly have probably less than 15%. The others can contribute on this. Of strokes are hemorrhagic. What does the group think?
Okay.
Yeah, exactly. So the group believes it's less than 15%, actually, close to 10.
So this is very interesting. So all this epidemiologic data that I presented to you probably not applying to your part of the world, eh?
Maybe actually, but again, we do see a lot of these cases, and I think your contact is included in the emails concerning this. So when we get the stroke database in place and get all the data into it, we can just get back to you and tell you what we found more precisely, because right now we are just doing rough estimations and that may not actually be accurate.
Yeah, but I mean, I appreciate your response, because if it was like 50%, you would obviously know it. So it's really not super common.
No, not super common, no, compared to ischemic strokes. Yeah.
Okay, that's very interesting. Thank you very much. Appreciate that. Okay.
Thank you.
Can I ask you also, do you guys use the ICH score for prognostication or for anything like that, or not really?
No, we use the ICH score a lot. Whenever we have a patient with ICH, they always move to the ICR when we get that. Unfortunately, I must confess, we've used it a lot for prognostication as well. Whenever we have something like an ICH score of 4, you read 97% mortality, and then, ooh, you get shocked, and maybe that can limit how aggressive you are in the management of these patients. So that's one of the good things I think your presentation also brought to us.
No, I mean, this is a very common thing, and I mean, we're not immune to this. Obviously, when you look at this score, it really is very compelling. I can tell you that the creator of the score, Dr. Hemphill, has actually spoken extensively about this. He never intended it to be a prognostication tool, but it definitely gives you an idea where you're heading. We have become a little more aggressive with these patients over the course of the time because we realize that sometimes we're quite pessimistic. And we've found out that even patients who look very poor in the early stages, they actually have surprisingly good outcomes. I'm not saying that they have MRS of 0, but they do a lot better than initially thought.
Okay, thank you.
And I think that the idea behind this is that although bleed looks impressive when you look at the CAT scan, it doesn't destroy the brain tissue the same way that ischemic stroke does. Ischemic stroke, really, whatever you see, is dead tissue. The hematoma, as we said, displaces the brain tissue, and it definitely results in a significant deficit. But over time, a lot of this, resolves, so it becomes less impressive in the long term, and that's probably why these patients end up doing probably even better than ischemic strokes in the long run.
Okay, that's good to know. That's all on our side.
Thank you very much for your questions. I appreciate greatly.
Thank you so much, Dr. Lioutas. And thank you everyone for joining our grand rounds. And you can see the recording in our YouTube channel, and I will also send the link to Dr. Tichinda. Yes.
Thank you.
Guys, I'm also happy to, I will send the slides to Mariam. So I make available to you, so you can have the slides actually with all the references and everything, and for your perusal.
Awesome. Thank you.
No
Great,
problem.
thank you.
Thank you all.
So have a good night.
Bye-bye.